It is 12, so I can go ahead and start. Yeah, so hello to everybody. Good afternoon. It's 12 noon today on June 7th. This is the June monthly meeting for CMDA, and I'm Sue Pallett, the president of CMDA. So really glad that you're all here, and I anticipate probably more people will join on as we go. But today we're actually going to start with the annual CMDA business meeting that will be led by Travis Neill. We're going to host the CMDA elections for the officers on the executive board, and Dr. Leslie Eber will conduct that. We have CHCA and CDPHE announcements, and the second half of today's meeting will be presented by Boyd Hammond, who will talk about aging LGBT patients. So welcome to everybody, and I'll go ahead and let Travis start.
All right, thanks, Dr. Pallett. And I'm sharing my screen so I can bring up the financials. While I'm doing that, I just want to kind of throw it out there for everyone that, keeping our mission in mind, which is to, connect the long-term care community and spread education as much as possible. We definitely like feedback from everybody. And it doesn't have to be on the call today. You can send us an email later, but be thinking about the things, any ideas you have for how to further that mission, how to, reach more providers, more staff actually in long-term care, and, basically use some of the funds that we've managed to make from the annual meeting. So with that, let me bring up the annual meeting P&L. So I think you can see that okay. So first, I'm just going to go through the annual meeting numbers, and then I'm going to briefly touch on our overall income statement for the past 3 years. It's been a strange 3 years, so you'll see that those numbers vary quite a bit, but just to hit the highlights. So the annual meeting P&L was quite good. We had a good turnout, especially considering this was sort of first comeback from the pandemic. With our registration revenue and vendor revenue totaling $50,000 after expenses, we profited a little over $17,000 with the conference, and then we pay CHCA 10% share of that profit for all the value that they bring to the conference and to us in general. And to compare that to last year, it was a little over $10,000 that we made. So we definitely did much better. It was really a good turnout for vendors this year in particular. And we've had certainly as discussions for, sort of the why that was the case, and, the value add with, having vendors at the conference and how many we have and so forth. But that's the overall numbers. And then let me switch to our P&L. So this is, let me see if I can get it on one screen. It's going to be hard to see. But so this is our income statement. It's a total transparency. It's everything, categorized in terms of our income and our expenses from 2020 through now. And so 2020, again, was the strangest year because we did not have a conference. And so we had a lot of just unusual things happen that year that don't normally happen. And so we actually had less money at the end of that year than we started, not by much. We came out pretty close to even, but obviously dealing with canceling the conference, which is our main revenue stream. And then 2021, was a profitable year for us. Again, we're not in this for profit, so pay attention to the expenses in terms of where we spend the money, and this is where we want feedback from the community on any ideas you have for how to use the funds that we do have. And so our bank account has steadily increased from 2020 through now. So as of the 31st of May of this year, we're at 48,000 in the bank account. Traditionally, we don't have a lot of expenses in the second half of the year. There are no real big ticket items that come on there. We do give to the futures program that usually happens at the end of the year, a couple $1,000s there. And then we have the AMDA participation, which is also something that tends to happen at the end of the year, even though it's for the following year. But essentially we're sitting good with our cash and have continued to increase that. So, really, that's the high level of our finances that I think we've been fiscally responsible considering the pandemic and, how to structure a virtual meeting, which we'd never done before, an all virtual annual meeting, and now a combo virtual and in person. So those are the new things for us. And fortunately, we had support from a consulting firm, Core Care. It was a big expense, but they provide a lot of value. And we didn't know what we were doing, so we needed it. And so we are always in talks for how to kind of keep those expenses low. But I think what we'd love for feedback from everyone is, how to utilize this money, and any ideas anyone has. We've talked to the board about some of the ways that we can maybe reach more providers, particularly rural providers. We think that the education that we provide both at the annual meeting, but as well as the monthlies, are really valuable for, they're value for everyone, particularly the rural providers that are a little cut off a lot of times. And so, as everybody here has contacts or maybe goes to rural communities, please let us know if you have some ideas for how to reach some of those providers, how to encourage participation in the meetings. And we can, throw around ideas about supporting people to go to AMDA, or even providing scholarships for people to come to the annual meeting if they're a rural provider. There's all kinds of ideas for ways we can try to improve engagement in the CMDA education and monthly meetings. So that's it. Why don't I don't want to take up too much time from the clinical piece here. Dr. Pallett, if we want to leave this open to questions now, or given the time, if we want to just let people email us if they have ideas, that's fine as well. But I will open it up briefly to questions if anybody has any.
Absolutely. We should take the feedback either online now or in the chat box or over an email. Any of those options are great. And thank you, Travis, for your leadership in putting this all together and calling us fiscally responsible. That sounds like a nice compliment for our group. And Dr. Eber is asking about possibly having TIPA Snow come and do a dementia training for our group, maybe at an annual conference. I think that's a wonderful idea. I know that we rejected it in the past because of the expense, but with the money that we have, that might be an option.
Yeah, definitely. And I think more ideas like that are definitely what we're looking for. We, again, we're not for profit. So, we balance, keeping some money in the bank account to be fiscally responsible with, spending it and making sure we're utilizing it for the good of education in particular. So definitely something like that is on the table and also a good idea.
Well, thank you. We'll let people mull over that and get back to me or any of the board members. We'd love to put your ideas into action. And not hearing anyone else chime in at the moment, I'll go ahead and turn it over to Dr. Leslie Eber, and she's going to conduct the annual officer elections.
Thank you so much, Dr. Pallett. It is an honor to talk about the exceptional CMDA slate for 2022-2023. CMDA is blessed with people willing to volunteer and lead in our community who are exceptional role models for us all. So I just want to thank every single officer for donating their time and their talent and their expertise. So thank you to you all. The slate for the CMDA officers are for President, Dr. Singh Pellet, Vice President, Allison Villegas, Treasurer, Travis Neill, Educational Coordinator, Galen Hartzucker, Community Liaison, Chris Horton, and that is our slate. Each of the officers are unopposed for this election for this year. And so I thought we would ask if you all want to unmute, we could just vote on the entire slate as one, because there's nobody who is being opposed in any officer position. And so every officer has been nominated and has agreed to the position that they've been nominated for. So if everyone wants to say yay, if you say yay, if you agree with the slate for the 2022-2023 CMDA officers, please say yay.
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 Are there any nays? All right, so the slate passes and we have our CMDA officers for this year. Congratulations to all the officers and a debt of gratitude to each one of you for serving. Thank you.
Thank you so much. I love working with this board too, and I look forward to another fun year. All right. Well, at this time, we will move on to the announcements from CHCA and CDPHE. Jenny Albertson, would you like to start? Is she on? I don't know if Jenny's on the call.
Yeah, I haven't seen her on
okay.
yet.
Okay. I know, and then Chad Fear with CDPHE. I know he was going to join late, so I don't know if he's on the call yet.
I can give an update if you'd like, a little bit on the strike team, if you want.
That would be terrific. Sorry, I didn't add that to the agenda yet.
Oh, no. So the residential strike team is continuing and they've had some adjustments in leadership. And so I think finding our footing again. It's a smaller group and meeting once a week on Tuesday. Right now, what we're talking about is the struggles for facilities that are in outbreak. How can we ensure that they have what they need? And what about preparing for the future? We are talking about how future outbreaks, we hope that this will evolve into something a little bit easier. And so what will that look like? And what will the fall bring? How will we manage that as well? So we talk about staffing, about PPE, about testing. Right now, we have been assured that testing will still be paid for by the state. And so that is a gift. And that the state will continue to help with staffing when needed. And that also, I think, will change over time. But our feedback to the governor's office and to the strike team, I think, is really useful for how much different facilities are struggling with staffing. And if facilities are struggling with acquisition of PPE, that's another area that the strike team can also help out with. In the future, I think that the strike team is hoping to morph to continue past COVID-19 and be a resource or a collaboration where whatever we're struggling with, whether it be neuro or dementia care or anything else, that this will be a collaboration that will continue. Thank you.
Leslie, can you tell us, are there ways that we as community members can contribute or help with the goals of the CDPHE strike team?
Sure. I encourage everybody on this call, if you see something, if you have a concern about something, please reach out. You can email Dr. Pellet, you can email me. We can bring your concerns forward. And that's what the representation of CMDA is supposed to do on the strike team, is to bring forward your ideas and your voices. So please never hesitate if you are struggling with something to share it with us. And I would be honored to bring your voices forward. So I think that, thank you.
Does anyone have questions or comments about the strike team? Well, Chad Fear is on the call with CDPHE. Hello, Chad.
Hi, good afternoon.
Afternoon. I know you said you didn't have much in the way of updates. Did you have any announcements you wanted to make? Or would you like to open it up to any questions from the community?
Just a couple things. Just wanted to make sure everybody was aware that CMS has been doing a number of oversight surveys, and these are focused. So what they've been doing is after we go out and conduct a recertification, at some point later, CMS has been going out and comparing, so they're on site as well at a later time, and they're focusing on behavioral health, immunizations, language and communication, infection preventionists, and while they're on site, they have an option to add another particular area that they want to look at, and they compare their findings with the findings of the CDPHE survey team. So just, you know, and it's one of those things. So the office is, CMS office for the region is in our state. And so we're the largest health department in our region. So we do get a number of the oversight activities conducted in our facilities. I just wanted to put that out there that, you know, don't be surprised if you do see that happen. The other thing would be, you know, with the changes to the definition of up to date, including the, you know, when folks are eligible to receive a second booster. From a survey perspective, we are not surveying to that requirement yet until we get the directive from CMS to do so. So when we're going out and we're looking at, and particularly the vaccination citation, requirements around vaccinations, you know, we're looking to see that that everybody's had the last in a series of their vaccinations, and that in order to meet the definition of up to date, that they've had the one booster. And so the booster is not required by CMS or us, but it does change how the facilities approach the additional precautions that are used for those folks that are not up to date. So those are the things we look at. But to this point, we will not be, until we get further direction, considering the second booster in the definition of update. And that's what I have for you all. Are there any questions?
I'm not familiar with the CMS oversight surveys. Is that like another survey in the nursing home facility, or something that happens within CDPHE?
It is. It happens. A survey team from CMS will follow up, follow our visit, and they will be on site. In this instance, and there's a number of ways that they do that. Sometimes they're full comparative surveys. In this particular example, they are focused on those 4 or 5 areas that I listed earlier. So those are the things.
Would you mind listing those again?
What?
Would you mind listing those items again that they're specifically looking at?
Sure. So it's behavior health. And there's 4 regulatory areas that they're looking at under behavior health. Immunizations, language and communication as an activity of daily living, infection preventionist, and then the 5th one is at their discretion. They'll add another area of something that you know, perhaps was a specific concern that was identified in the CDPHE survey, or something that they see on site and would want to include that, and then compare whether the CDPHE survey surveyor also saw the same kind of things.
And they select the facilities randomly?
They do.
Can I ask one other question as well, Chaz?
Yes.
So in terms of the immunization parts, both from a CDPHE perspective and from the CMS oversight survey, are you looking at not only the rates of, say, COVID-19 boostering, but the education or the interventions that are associated with that? So say a facility doesn't have a huge boosted staff, but have done due diligence about education. Can you talk a little bit more about how you gauge those measurements?
Sure. You're very right. Educating staff is an important part of that, making sure that staff understand the importance of getting the booster and then offering an opportunity to get that booster. While the booster isn't required, those other pieces are a part of what we look at when we go out. Now, what that entails may differ from facility to facility, but we do need to see that those actions, those efforts have taken place.
Thank you.
Yes.
Are there other questions for Chad? Hopefully you can all hear me. I'm sorry for the background noise. It's always good timing when we're cleaning our house. We do have a speaker for the second half of today's meeting, and I think he's still yet to join on. We can take a few moments to do some announcements. One is that we are hoping to, hi Boyd. We are hoping to have some elections in October for board members at large. And we will get some information out to everybody to know what to expect and what that means, and see if any of you on this call would like to serve on the board in a different capacity than on the executive committee. And so we'll put some more thought into it and spell it out more clearly, but this would be a great chance to invite other people to join CMDA and join our board and have some leadership roles. So I hope you'll consider it and let us know if you have any questions. And it looks like Boyd is on our call. I'm going to go ahead and make you a co-host, and then you can share your slides. If you prefer that I show the slides, I'm happy to do that too.
No, yeah, I'd love to share my screen. That'd be great.
Okay, sure. Take your time.
And while we're waiting for him to get the slides up, can I go ahead and introduce him?
Oh, please do.
Yeah, awesome. So really excited to have Boyd here today. This is kind of in honor of Pride Month. So he'll be talking to us about aging LGBTQ patients. Boyd Hammond is faculty at the University of Colorado and works with the PA program and with the Division of Endocrinology, Metabolism, and Diabetes. Clinically, he works in the integrated transgender program, providing gender-affirming hormone therapy, as well as with the student-run free clinic on Diabetes Night. He is a sub-investigator on clinic trials evaluating aging in transgender patients. And he's also involved with the DEI efforts on campus. And thank you so much for being here, Boyd. I'm really excited for your talk.
Awesome, great. Yeah, thanks for having me. Can everyone see the slides and hear me okay? Thumbs up. Okay, perfect. Well, thank you, Allison, for the introduction. I wanted to start off by, there we go, saying Happy Pride Month to everyone. I think it's awesome that you wanted us to be here and talk about this important topic. And so thank you, and Happy Pride Month to everyone for the month of June. So why do we need to talk about aging LGBT patients? And I think the answer is because we know that our LGBT patients are aging. And so if this isn't something you're seeing yet, it's something that you're likely going to start seeing. And so being aware of these medications that the patients are on and being able to continue these medications or maybe even start them might be in your wheelhouse at some point. I'll say before I even go into some of this data, but just anecdotally, I have now, I think 3 patients that are in long-term care facilities who I've seen and started on hormones. And so it's something that, you know, you will likely see at some point in the future. So we don't have great recent data for the age of our transgender patients. The largest survey that we do have was done in 2015. So I think that since then, patients are likely even older than what we see in this graph. But as you can see, trans women, 5% at that time, were over 65. And then trans men and non-binary patients, definitely a lower percentage of them were 65 and older. But you'll notice here that 20% of people who self-identified as cross-dressers were 65 and older. So that might be the terminology that's more common in our older patients and not something we see as often anymore, but that's how some of these patients who aren't comfortable necessarily with the definition of transgender might identify. And that doesn't mean that they aren't interested in medical transitioning. Also, people who identify as cross-dressers might not be anywhere in the transgender spectrum, and we'll talk a little bit about definitions as well. And then outside of transgender, so the 2021 US Census data showed that 8.1% of adults over the age of 65 identify as LGBT. So that's a pretty good chunk, right? I mean, before long, we probably are looking at 1 in 10 of the patients over the age of 65 identifying as LGBT. So definitely people that you'll be seeing in your practice. So I think that's why it's an awesome topic for today. I want to let you know I'll focus mostly on transgender patients because that's what I mostly see. And also, that's where, you know, a lot of the medical care really comes in for these patients. And then also I want to say that really we have a lot more questions than answers for our aging transgender patients. And so we know there's some things that we want to take into account when treating these patients, but we also know there's a lot that we need to figure out because of the fact that our transgender patients are aging. So some terminology in case this is new for you, but gender identity. So that's the way someone feels on the inside, and that can be as a man, woman, or something else. And this can or cannot correspond to the person's external body or assigned sex at birth. So you'll hear for new terminology, patients can say they were assigned female at birth or assigned male at birth, and people use the abbreviation AFAB or AMAB to signify that. And then their gender identity can either match that or not. But another really important thing to keep in mind is that sexual identity is definitely a different definition for a lot of patients than their gender identity. So we don't think of those two things as a synonym. They're very different. And so someone's sexual identity really doesn't have to do with their gender identity. And then gender expression. So that's the external manifestation of a person's gender identity. And so sometimes that conforms to the socially defined behaviors or what we think someone should look like based on our idea of what it means to be masculine or feminine. And sometimes patients who are transgender and their gender identity doesn't match their sex assigned at birth don't feel comfortable to change their gender expression. So those things might not match either. But then patients whose gender identity doesn't match their sex assigned at birth, they might express their gender that they identify with, in which case that would look different to us than what we think that someone should look like based on our definition of male or female. And then something to keep in mind is that this goes farther than just clothes. So we think of mannerisms like movement, the way someone grooms, definitely things like speech patterns, social interactions, all of that goes into the way someone expresses their gender. And then our last definition is transgender. So this is an umbrella term for people whose gender identity doesn't match their assigned sex at birth. Some people use this to include intersex people, and we have intersex patients who do identify as transgender, and some intersex patients do not identify as transgender. So that's something that's really specific to the individual. And then sometimes people only use this definition for trans men and trans women. And then non-binary people tend to identify under this umbrella term of transgender. And transgender people may or may not choose to hormonally or surgically transition. So we definitely have patients who are interested in only one or the other, or who are not interested in any hormones or surgeries at all. So that's something that also varies individual by individual. So then first, I just wanted to talk about making an inclusive space for your patients. And so I realized that some of this doesn't exactly apply to long-term care facilities, but in case your practice also includes seeing patients in a clinic. But things we like to talk about is a physical sign. So here's a safe zone sign that's really easy to find on the internet, but that can make patients feel comfortable. But something that you can have that you can go to different facilities with would be something like a stethoscope pin. So, you know, maybe it's a rainbow flag, or maybe it's having your pronouns as a pin on your stethoscope, or even having your pronouns on your badge or something like that. So that's something that I think would apply to going from facility to facility, that lets your patients know that you're a safe person to have those conversations with, especially when they need to. And then we like to talk about inclusive paperwork. So really with gender spaces on history forms, we really like that to just be a blank space, so that the patient can write whatever they feel, and not just having a circle for male or a circle for female. And then also asking patients their pronouns, which I know, I mean, I should have said through high school and college, I worked in long-term care facilities actually. And I can imagine with this population, you know, that may bring up a lot more questions from your patients than maybe you have time for one to talk about. But it really does make a difference in patients feeling safe talking about that. So it might be something simple like saying, my name is Boyd Hammond, I use he, him pronouns, and you don't necessarily even have to ask the patient, but that invites them to share if they do want to. Something else that's more clinic specific, but you know, we're trying to move more gender neutral restrooms, since that's an area of a lot of dysphoria for our transgender patients. So that's more applicable to clinic really. But those are some simple ways that you can show that you're a safe person for patients to talk to. And something like, I think the pins on your stethoscope would be the best starting point if you don't feel comfortable saying your pronouns or asking. But I think if a patient is looking for that, they'd notice it. And maybe if they're not looking, they wouldn't ask questions. So I think of that as a great starting point. So then I wanted to spend some time just going over the basics of our masculinizing and feminizing gender affirming hormone therapy, since you'll likely either already are seeing patients on these medications or will be seeing patients on these medications at some point. And then at the end, definitely talk about some points that are specific to our older patients. So first of all, to review the requirements for starting gender-affirming hormone therapy. And as you can see, this is based on the Endocrine Society guidelines, as well as WPATH, the World Professional Association for Transgender Health. So we do require persistent, long-standing documented gender dysphoria or incongruence. And to hit on that for a second, we used to require patients see a mental health provider to get a letter that says, that documents that. But generally now we're moving all over the country more towards an informed consent model, where we really feel like primary care providers and endocrinology providers and really in many areas of medicine, providers can make that diagnosis. And so that's moving away from what some people call gatekeeping and more towards the informed consent model. That being said, I still have many patients where if the picture is not super clear, I definitely have them see mental health first. But if they tell you ever since childhood or puberty, they felt like they were in the wrong body, they started socially transitioning at a younger age, at least around people they were comfortable with, then it's pretty easy to make that diagnosis by yourself. But it's never a bad move to have a patient see a mental health provider. And then in general, we just recommend they have a mental health provider, right? So hopefully patients have someone that they're already talking to or are open to that. And then capacity to make healthcare decisions. So that certainly can apply to some older patients, I would imagine, and also to our, we have patients with different learning disabilities and whatnot, where I do ask for a psychiatrist to help make sure that they feel they do have capacity to be making their own healthcare decisions. Age of majority in the country, so 18 in US, and this is for adults. I don't see pediatrics, but without that, then you need parental consent. So this is to provide this kind of care without any parental consent. And then psychiatric and mental condition or medical conditions should be stable. Sometimes we use well controlled, but really a lot of our patients with gender dysphoria tend to have, pretty significant depression that I wouldn't necessarily call well controlled when we start helping them with their transition, and then those tend to really improve over time. So that's why it's at least stable, no active suicidal ideation before starting something like a hormone on these patients. So this is what we use for our masculinizing therapy. So for masculinizing therapy, we only have to use testosterone. You'll see that with feminizing therapy, testosterone is the stronger of the sex hormones, and we do have to use some sort of anti-androgen therapy. But for masculinizing therapy, we just use testosterone. And these are the routes we normally use here in the US. So injections with either cypionate or inanthate, or the testosterone patch or gel. These are typical initial doses. So this would be something that you might see. We do weekly injections of the shots. I know sometimes in other therapies like low testosterone, sometimes they use every 2 weeks, but we feel like it helps with cyclical symptoms and removing some of the peak and trough if you do weekly injections. So that's what we tend to use. And then the other thing you might notice here as a difference is we often do a lot of sub-Q injections with our transgender patients with testosterone, and that's not really common in the testosterone replacement in cis men yet, but the research shows that you get a similar amount of absorption using a similar dose and similar safety profile. So since it's an easier injection for patients to do, then we use a lot of sub-Q. The patch, of course, super easy, keeps an even level for the patient. They just have to change it every day. You're also a little limited in the doses with only a couple of options though. And then testosterone gel we do use, and as you all are, I'm sure, are aware, you want to make sure the patient's not coming into contact with people or animals after applying the gel. And then what levels should you be monitoring for in these patients? So these there's lots of recommendations that have varying conservative versus, more less frequent checks. And so this is what we use in our practice at CU for the most part. So testosterone, we check every 3 months for the first year. And then really you only need to check 1 to 2 times yearly once the patient's on a steady dose and labs have looked good for a while. In the elderly, should we be checking more often? That's one of our questions, but this is kind of what we go off of right now. And then hematocrit. So as you're probably aware, testosterone can raise hematocrit. So we do follow that closely as well. So we check that to see what level it's like at baseline. If their hematocrit's high at baseline, we often have them do a sleep study. We can ask about smoking and whatnot. And then if hematocrit is high, we tend to use the gel or the patch over the injections because those have been shown to raise hematocrit less than the injections do. And then you'll check every 3 months for the first year and 1 to 2 times after that. Liver enzymes, I would say we still actually check decently frequently, but there's not a great reason for that. There's not much of a recommendation given the safety profile of the testosterones that we use here. There are testosterones that are used in other countries where we do see elevated liver enzymes, but here I know there was just the oral testosterone that was just approved by the FDA. We haven't started using it yet because insurance doesn't cover it, and so it's not a feasible option for many of our patients. But they say that this new oral formulation won't raise liver enzymes or affect your liver, which is awesome. So, and then we know that testosterone affects the overall metabolic picture of the patient. So we check lipids, A1C, and blood pressure at regular intervals as well. And of course, that also depends on any other medical conditions they have, where these might be a lot more frequent, especially probably in our older patients. And what levels are we looking for? So our testosterone, we like to be between 400 and 700, and you want to check that mid-cycle if they're on injection. So if they do their injection on Monday, you want to be looking maybe Wednesday or Thursday to check this level. If they're on a different formulation, we like it there at any time that we draw the labs. Hemoglobin and hematocrit, we tend to use the upper limit of normal. We use male values, and the lower limit of normal using male values as well. But if the patient is still menstruating or having spotting, sometimes we can use female values for that lower limit. Other labs we haven't really studied well, whether we should be using male reference ranges or female reference ranges. So that's another thing that we'll hopefully know more about in the future. And then we also don't know yet, should we be adjusting these goals as our patients age? So as cis men age, we know that testosterone levels definitely decrease over time. And so a big question right now is, should we be lowering testosterone doses and lower our testosterone goal in our trans men who are aging? The answer is probably, but there's no real recommendation yet as far as how much to adjust this by. Of course, if they have the tissue, you just monitor it like anybody else. So pap smears, if they have cervical tissue, screen per ACOG guidelines. Osteoporosis, so testosterone should, in a sense, be preventative against osteoporosis. But in our patients who are non-compliant with testosterone, or if they stop testosterone after they've had an ovarectomy, for instance, then we definitely want to be screening these patients for osteoporosis. Breast cancer screenings, again, per the normal guidelines, and then STI testing, of course, as indicated. So feminizing therapy, to go over this briefly as well for you. So I just have this up here to show you it's the same. So the same criteria for starting feminizing gender affirming hormone therapy. Our estrogen options. So a lot of our patients are on oral estrogen. It's probably the most common just because that's what patients have used over time for a long time. Doesn't mean it's the best option. We also have two different types of injections for estrogen, valerate and cypionate. And then we have our estrogen patch. And so here are some typical initial doses for you. Some notes, we can keep the oral dose more of an even dosing if you divide BID. So we tend to do that once over just 2 milligrams. With the shots, we tend to do weekly injections, but you get a lot of cyclical symptoms with estrogen injections. And so it's something to have your patients monitor for. The patch, of course, gives us the even dosing. And I'll show you this again later, but we tend to only use the patch in patients over 50. So that might be what you see the most often. And that's because of the VTE risk increasing in our older patients. And we know that the patch has the lowest risk of that. So we really try to push hard for a patch in our patients over 50. So I imagine that's what you'll mostly see. And then we also recommend patch for patients who have an unhealthy lipid profile or who are smokers or anything else that will raise their baseline risk anyways. And then we have to use an anti-androgen therapy. And so it's an extra medication. You'll see spironolactone used the most often. We try to keep that twice a day as well once we get over that initial dose. Otherwise, we get something called testosterone escape, where your testosterone can increase after 12 or so hours after you took your spironolactone. It's the most commonly used, but it's not always tolerated. It does increase urination. It can cause hypotension. Patients can have dizziness. I've had patients faint that seem to be really sensitive to it. So our other options, most that we use really are finasteride and dutasteride. Dutasteride has some evidence to have some more feminizing effects. So that's the one I tend to use. But what we're pushing for, or pushing is not the right word, but what I'm surprised we don't have more of here in the US is orchiectomies. So in Europe, most of our trans women, even if they choose not to have other bottom surgery, they tend to have orchiectomies and have their testicles removed, which removes the reason to have an anti-androgen therapy, and we don't have to have those on board anymore, which obviously is just nice over time, reducing medications, reducing side effects, reducing monitoring. And so it's interesting that it's much more of the culture in Europe than it is here, because in Europe, older trans women that you'd be seeing would normally have had an orchiectomy, but here you'll still find lots of patients on anti-androgen therapy, even as they age. This should look really familiar, so won't spend a ton of time on it. The same frequency for estrogen and testosterone. We still measure electrolytes if on spironolactone. There's not actually that great of evidence that says you need to. Our derm colleagues that use it for acne said that they've stopped, I guess, but we still follow, mostly that potassium while they're on spironolactone. And then lipids as well. We know that estrogen can have a negative impact, especially on triglycerides. So we do watch that pretty regularly as well. Goals for your estrogen is 100 to 200. Mid-cycle if using injections. Again, should those goals be changing with patient's age? We don't know yet. And then we try to get the testosterone under 50. So specific takeaways for older patients, older transgender patients. First of all, we think gender affirming hormone therapy should really be continued lifelong. So that's why I do think you'll start to see more of this if you haven't already, but we continue in all of our patients that we continue gender affirming hormone therapy for their entire life. As trans women age, the risk of VTE increases. And so we really recommend using the estrogen patch in patients who are over 50. If I have a patient who's over 50 and a smoker, I will refuse to use anything else. But definitely it's what we recommend in patients who are over 50. If trans women are able to have an orchiectomy, it's a conversation we should be having with these patients because it eliminates that need for that anti-androgen therapy, which eases the burden of their care and additional medications. And then what should we do about dosing when patients get older? So should we be using lower testosterone doses in older men? No consensus yet on changing goals for this population, but I think the important thing is just monitoring closely other markers, especially their hematocrit, their lipids, looking for any evidence of cardiovascular disease, and then maybe increased cancer screenings in these patients that are on these hormones for a lot longer. And there's no recommendations for these yet in our older trans patients. And so these are just things to look out for and hopefully we'll have more guidance on in the future, but things to keep in mind for sure. So I just wanted to highlight a few of the studies at CU. So these are the studies that I'm a sub-investigator on, but Dr. Sean Iwamoto is the primary investigator. So we're looking at the evaluations of aging and gender affirming hormone therapy on vascular endothelial function, and then some metabolic profile labs in trans women compared to age group matched cisgender adults. And the second one you'll see looks very similar, but in our trans men. And then we're also studying the effects of orchiectomy in age on vascular and metabolic health in older versus younger transgender women. And that might give us more evidence to really recommend orchiectomy in our trans women especially as they age, so that we can not use extra medications, and you can use a lower estrogen dose in general too. So hopefully there'll be more information to come from these studies and studies that are happening around the country and the world. The last thing I want to touch on is HIV. We do know that almost 1 in 6 new HIV diagnoses occurs in patients over 50 years old. And the research says that we don't have many patients over 50 on PrEP, but a lot of them meet the guidelines for starting PrEP, which is anyone at an increased risk for getting HIV, which does include a lot of straight men now too as well, depending on the guidelines, depending on who they're having sex with and who those people are having sex with. So, so something to keep in mind. And then the thing I wanted to point out specifically for our older populations is that we do know that Descovy is a safer medication for PrEP than Truvada for patients with osteoporosis or kidney disease. So I feel like in our older patients, we'd probably be using a lot more Descovy. And then an added bonus is Descovy is a smaller pill. And I know that as someone that used to pass meds in long-term care facilities, that the bigger the pill, the harder for our older patients to swallow. So just an added bonus there. And that's it. So it's kind of a whirlwind of information. And like I said, unfortunately, we have a lot more questions than answers about our older trans patients, but the important thing is you'll be seeing a lot more of these patients, I feel like, and hopefully we'll have more answers and more guidelines as time goes on. So.
Thank you. That's really wonderful. I learned a lot just in this very short time period. And we'd like to open it up to questions. And oh, there is a question in the chat box. Is the use of PrEP for a specific time length?
So PrEP is as long as they are at risk for getting HIV. So until they stop the activities that you're worried about, then you'd continue PrEP in those patients. And we could have done a whole lecture on PrEP and how now we have the 2-1-1 method, which isn't quite FDA approved here yet, but it's being studied, where patients take 2 pills the day they have sex, 1 after that and 1 the day after that, to reduce the burden of medication and potential for side effects. And I think that's something we'll see more. And then now we also have the PrEP shot, which isn't covered by insurance yet, but it's going to be a 2-month shot. It's here, it's just really expensive and not covered yet. But yeah, that's an awesome question.
And can you clarify for me, when we're documenting in the medical record, what is the right term to use for a transgender man or woman to make it really clear
Yeah,
that we're referring to the right person?
That's an awesome question. So we just say transgender male or transgender female. And I know previously it was used a lot more male to female or female to male, but we avoid that and we just say transgender male or transgender female, or a non-binary person, 31-year-old non-binary patient. So.
And I was glad to hear that you've had some patients who are long-term care residents. Have you experienced some issues with roommate assignments? There's a transgender male or transgender female who's undergoing hormone therapy, at which point do they need to consider perhaps a different roommate assignment?
That's a great question. I don't think that's come up for me. I have a patient who moved into a private room who was in a long-term care facility, but I think it was multifactorial. I don't know if it was just from their hormone therapy, but yeah, that's something that hopefully long-term care facilities can be sensitive to if they need to for patients.
And I can just say at one of my facilities, we do have a transgender female, and they just make sure that everybody in the room is understanding and appreciative and accepting, and it hasn't really presented an issue. But I do know that when they talked about it, they were really worried about HIPAA, but they had the resident obviously gave permission to kind of share that to make sure that everybody was comfortable with the roommate assignments. I think moving forward, we'll see more of that.
And then it looked like Leslie had her
Yes.
hand up.
Yes, thank you so much. Thank you for this great presentation. I learned a lot. I wonder if you've heard if any long-term care facilities or assisted livings have policies and procedures to kind of sort out how to navigate these waters respectfully and appropriately.
That's a great question, and no, I think that it is so new. Not that I've heard of yet, and not with the long-term care facilities I've worked with in my anecdotal experience of a few patients. It's not something I've seen. I do know there's a few independent living facilities out there now that are advertised themselves as either LGBT friendly or really exclusively LGBT. I've heard of those in New York, San Francisco, places like that. But I don't know if anyone else here could speak to policies that they've encountered.
It seems like that's something that we could work on and make sure are available so that everybody's not reinventing the wheel. If we could do some education on that and have something that we can share. Thank you again.
Yeah.
Agree with that. And I know that you had mentioned that the gender affirming hormone therapy should be used lifelong. And often we'll deal with people at the very end of their life, and it's at the very end of life when people perhaps aren't suitable to take hormone therapy or can no longer take medications. I'm just wondering if you've dealt with that and what kind of impact it might have on the person as they're maybe reversing their hormone therapy at the end of life.
Yeah, so that's a great question too. And a lot of the changes from these hormones, which we go over with the patient, are permanent. And so there's a lot of things that they won't notice drastic differences in towards the end of life, especially. and you know, I think about things like we really want to suppress menstruation, but that won't be an issue, of course, anymore. And so I think that a lot of things patients wouldn't necessarily notice drastic changes in, especially as they get really close to the end of their lives. We talk to you know, ICUs and in people and whatnot, and talk about how really these medications are pretty safe to continue close to that, though, because unless, you know, the patient just had a stroke, of course, and you have them on estrogen, then you'd probably want to reevaluate, and if they're close to the end of life, or if the patient's hematocrite's getting super high in testosterone. But in most circumstances, we continue them, you know, pretty long. But I would say that it could, you know, take some education with the patient that they probably won't notice drastic changes when they're, you know, close to the end of life if they stop the medications.
Well, thank you for putting your email up on the slide too.
Oh, yep. Yeah. Yeah, I go by my middle name Boyd, but my email's Daniel. But
Who is that?
yep.
Thank you. If other people have questions, please ask them, and we will be sure to send the slides out to our members for this very important topic. Okay. Well, thank you so much, Boyd. Thanks for taking the time to
of course.
put the slides together.
Awesome. I'll stop sharing.
Appreciate it.
Perfect. All right. Thank you.
Thank you so much. We do have 5 minutes left, and we're happy to take any questions or comments. I know that Jenny Albertson wasn't able to make her announcements before, but I think she has another meeting to get to. All right, if there are no further questions or comments, we'll go ahead and wrap up today's meeting. Thank you so much for joining us. There will be no CMDA meeting in July because of the July 4th weekend. So our next meeting will be the first Tuesday in August. Thank you, everyone.